Okay, welcome everyone to our 10th meeting in our 2021 virtual meeting series. Thanks everyone for being here. And it's always, we're always glad to see your smiling faces. Thank you to Dr. Heather Lau for providing a presentation tonight on cerebrovascular involvement in Fabry disease. And normally my co-host Dawn is by my side, keeping me out of trouble and doing most of the introduction and FAQs, but I'm alone tonight, so we'll have to just manage with Dr. Lau and myself. So anyway, welcome again. Dr. Lau is an assistant professor at the New York School of Medicine. She's board certified neurologist with special qualifications in child neurology. I won't read her whole bio because you can get it in the speakers and bios tab online on the registration website. But she is currently working at NYU School of Medicine as a professor in child neurology and the director of the NYU Lysosomal Storage Disorders program at the NYU Langone Health. So she has a great deal of experience with Fabry disease and other lysosomal storage disorders. And we're always pleased to have her come and see us and provide a presentation. So welcome, Heather Lau, and you can share your screen whenever you're ready.
Excellent. Thank you so much for inviting me here today. I'm going to start sharing in 1 second. So this lecture is part of a series of talks that I've given before, but it's always important to kind of revisit specifically the neurologic manifestations of Fabry. And today we're going to focus on the cerebrovascular aspects. I would like to let you all know that as of about 5 weeks ago, I have actually joined full-time with Ultragenyx. I'm now the clinical development lead. So I'm the executive director of global clinical development at Ultragenyx, developing a variety of therapies for rare diseases. In the past year, I obviously worked with NYU in the role of principal investigator for a variety of.
Excuse me, Dr. Lau, sorry to interrupt. Are you able to turn your volume up?
Probably not. I can try to, can you hear me now? I can talk louder.
Everyone, if you try to talk louder, if everyone else turn your volume up on your end, that'll be helpful also.
Okay, because I can't see the chat screen. So just, Jerry, let me know if I need to do something different.
Okay.
Can you hear me? Okay. So
And one other thing while we're paused for a second, I don't know if everyone knows about this, but if you look at your bottom menu on Zoom, you'll see CC live transcript. You can read closed caption if you don't already see that, which I use all the time. All right, sorry, go ahead.
That's fine. So, so I'm actually just stepped down as the director of lysosomal at NYU, and I've joined Ultragenyx, and it's been a bit of a big change, but I still will be working with the lysosomal community. Okay, so I always like to go back and look at what Fabry did, what the effects of Fabry is on the nervous system. So we'll go a little bit into the anatomy of the central nervous system and understand what the difference is between the central nervous system and the peripheral, because that's helpful to understand the different types of signs and symptoms that we experience. And then we'll go specifically into a stroke and focusing there. So this is again, we might touch on the white matter lesions and what happens in cranial nerve 8, but that's because sometimes we confuse peripheral symptoms with central nervous system symptoms, and that might be a critical determination for us. I'll go into why in a moment. So Fabry disease affects both the central nervous system and the peripheral nervous system. And the central nervous system is the brain and the spinal cord. So all of those nerves that come out of the brain, the neurons in the brain that form the gray matter and the white matter, come together to form the spinal cord. And then out, just as it exits the spinal cord, it becomes the peripheral system. And that's all the nerves and ganglia outside of the brain and spinal cord. And those are the messengers that from the brain to the motor functions, to the motor nerves to tell you how to move. And then the reverse, taking sensation from the periphery and bringing those messages through the peripheral nerves back to the brain. And then there's something called the autonomic system, which is controls bodily function. So here's another schematic here of the peripheral nervous system. We have the motor neurons that go and tell us how to move. We have the autonomic motor neurons that tell us to breathe, our heart to beat, and to rest and digest in our hormones and in our gut, and the enteric division here. And then obviously all our sensation goes back. And that's really important because sometimes we might experience a symptom, and as the patient, we may not know if it's coming from the sensory nerves that are affected in Fabry or in the brain, and could be heralding a stroke. Okay, and just this goes into a little bit more just to realize how much of our organs rely on the nervous system. There's really a mind-body connection when we think about how we digest, how we breathe, even down to urination and other functions. Here we can see saliva, our tear ducts, and how we, our motility of our gut, either pro-motility or inhibits motility. Everything is connected back to the brain, okay? And so when we think about Fabry peripheral dysfunction, we think about the nerves getting stored up with this GL3 accumulation. And I won't focus too much here on the peripheral nervous system, but again, what happens with our enzyme deficiency state, it leads to the accumulation of this lipid called GL3, and that can deposit in the cells that provide insulation to the nerves. It can deposit within the blood vessel walls, and it can cause peripheral nerve damage. But today, and so here we go here. So when we look at Fabry, which is a multisystemic disorder, we see that there's so many different ways it affects our nervous system, okay? So again, back to autonomic, we have abnormal sweating, we have reduced salivation, exercise intolerance, GI dysmotility, and cardiac arrhythmias are all due to underlying nervous system dysfunction. Okay, so let's go into the central nervous system in more detail. So how is the central nervous system affected in Fabry? Well, what I said earlier about the enzyme deficiency state, right, leading to this deposition of the substrate, GL3 for short, gets into the walls of the blood vessels that feed the brain. And so as we see here, this is the brain, and this is the base of the brain, as if you're looking up underneath someone's brain. And there's this wonderful vascular supply that nourishes all parts of the brain. And so all of these vessels are critical to supplying oxygen to the brain and carrying away waste products like carbon dioxide. And so what happens in Fabry disease is that the blood vessels become distorted from the GL3 accumulation. And we think it might lead to some inflammation, some pro-oxidant or reactive oxygen species damage, hypertrophy, some prothrombotic factors. So the same things that we worry about, how it affects the blood vessels and the rest of the body, it can affect the brain. And so these vessels are vulnerable to damage. Now, there is some evidence of direct deposition in the brain cells themselves, so directly in the neurons. So that can also contribute to neurologic dysfunction. But primarily what we're thinking of or talking about today is the vascular compromise that's associated with Fabry, leading to stroke. So strokes are the term that we all know about a sudden onset of a loss of neurologic function. Now, mini strokes or TIAs are also strokes, but they don't lead to permanent damage, okay? And we'll go a little bit more into detail. So what is a stroke and how does it occur in Fabry? Well, stroke is by definition the sudden death of brain cells due to lack of oxygen. Now, that lack of oxygen could be caused by blockage of blood flow, see down here, is a blockage in that blood vessel, becomes narrow, and it cuts off the blood supply. And that leads to cutting off oxygen in this region of the brain, and that brain tissue dies. And the way the brain is constructed is that each part of the brain is responsible for a function in the body. So if you lose the part that helps you to speak, then you lose speech. If it's the part that helps you move your right arm, then you lose your ability to move that arm. So the ischemic stroke is the type of stroke where we cut off oxygen because we blocked the vessel. Another type of stroke that can occur in Fabry is called the hemorrhagic stroke. And that's where, same thing, the blood vessel is damaged, but this time it leaks and leads to bleeding. And that bleeding also leads to that tissue not being nourished with oxygen, oxygenated blood. And so when that happens, you also have cell damage and eventual death of brain cells. So by definition, a completed stroke, a stroke, is death of brain tissue. Now, the transient ischemic attack, or TIA, or mini stroke, same mechanism where there's a brief occlusion of the vessel. Usually this is more of a ischemic type, right? And then that clot all of a sudden breaks up for some reason, and it opens up and allows the blood flow back, and the symptoms go away. So that's great, right? A mini stroke is not as bad as a real stroke or a completed stroke, but it tells the doctor that you are at risk. So the warning is still there. You got lucky this time, you can still have another stroke. Don't ignore that. Don't ignore brief loss of neurologic function, because that means that you are a setup for stroke. And this goes for people with or without Fabry disease. So in Fabry, we think the abnormal vessel walls become prone to occlusion or fragile and rupture. Now, there's other ways that patients with Fabry can have strokes, and that's because of the heart dysfunction, especially if you have arrhythmia or AFib, and there's a turbulent flow to throw off clots from the heart. So that's another way that that happens. And if you're with your cardiologist, they might put you on aspirin to prevent the clotting, okay? So that's really important to understand that there's two main types of stroke, and we see both of them in Fabry. However, how common is stroke in Fabry disease? Well, when we look at a Fabry registry, one of the largest registries of Fabry disease that's put together by Sanofi, they found a prevalence. So when they looked at the registry, how many men and how many women had had a history of stroke, up to 7% in men and 4% in women. And they look over their lifetime, it could range from anywhere to 13 to 25% of all patients. And obviously, as you age, the stroke risk increases, as it does for patients without Fabry disease. Now, the ischemic stroke, not the hemorrhagic, is more common. And there's a higher frequency of TIAs as well. The hemorrhagic events are less common, but they're still more common in men than women. In this registry, 17% of men, whereas 7% of women had a bleeding type of stroke. Now, what's interesting is the age at first stroke. When we think about stroke in the general population without Fabry disease, we think that the risk is highest. Well, we know that it's higher the older you are. So if you're 60, 70, or 80 years old, you're at higher risk of a stroke than a 20, 30, or 40. But Fabry disease itself is a risk factor for younger onset cryptogenic stroke, or stroke of unknown etiology. And the median age at first stroke is 39 for men and 46 years for women. And those are the studies below. So it's really important that if you are living with Fabry disease, that you understand the signs and symptoms of stroke. And actually, your family should understand the signs and symptoms of stroke, because sometimes you may not be aware that you have loss of function. So people ask me, well, what kind of symptoms are a sign of a stroke? Well, the brain controls everything, and strokes can occur anywhere in the brain, whether it's in the front or the back. And so the symptoms of the stroke are based on what part of the brain is affected. And that actually helps the doctors in the emergency room and the neurologists based on what symptoms you're experiencing, we can figure out where in the brain it is, even without doing imaging. So certain symptoms can be sudden, and they can include slurred speech or unintelligible speech, where you think you're making sense, but nobody's understanding what you're saying. So that's a speech that's affecting the speech area of the brain. Slurred speech could be in the back of the brain. It could be an asymmetric smile or a droop, right? A facial droop, sudden weakness of the arm or leg, that's an obvious one, but also difficulty understanding language or confusion. Someone is trying to explain something to you and you don't know how to do it or how to execute the command. That could be a stroke. It's more than just being foggy or not concentrating. It's actually not understanding how to tie your shoe all of a sudden, or open a door, or brush your teeth. It can also be, and this is kind of complicated, it could be sudden onset of vertigo or dizziness. So that feeling or sensation of motion. But a lot of you, right, also have vertigo, not because you're having a stroke, but because Fabry affects the inner ear or cranial nerve 8. So if it's your first episode of dizziness or vertigo and you've never experienced that before, you need to urgently get it looked at, possibly even going to the emergency room, because that could be a posterior circulation stroke affecting cranial, the part of the brain that goes into the inner ear. It could actually be a stroke. Vision loss or double vision also can occur. Now, strokes can be silent. Some of you might undergo a surveillance brain MRI, and some of you might have been told that, well, we see a history or evidence of an old stroke. Well, that is important information, because that tells us that you're at risk of another stroke, that your vessels are fragile. So the strokes can be silent. It happened, you might not recall the actual episode, but it wasn't severe enough to bring you to medical attention. Now, why is it important to recognize stroke? Well, there's two main reasons. Immediately, there could be something done to help you recover quicker from the stroke or prevent extensive damage. And that's called giving a clot buster, called TPA. It's controversial in certain disorders, but that is for the neurologist to figure out once you arrive to the emergency room. But if it's after a long period of time and you've not sought medical attention, you may not be eligible for it. And the first thing that they need to do when you go to the ER is to make sure it's not a bleeding stroke, because you would not want to give TPA to a bleeding stroke. So that's why it's important to go, because if it's an ischemic stroke and there's a current blockage, there's ways to unblock that artery potentially, either through an IV medication or even through a interventional radiology procedure. And you need to do that within a certain window of time. So you have to go as soon as possible. Okay. So is there a way to predict those of you who could get a stroke? So those with Fabry, right, that puts you at increased risk, but not everybody with Fabry goes on to have a stroke. So how can we differentiate who gets what? It is difficult, but what we do is we look at the information provided. So in a study in 2018, they looked at 159 genetically confirmed Fabry patients who did not have atrial fibrillation, right? So they took out the cardiac contribution to stroke. So because AFib alone can cause stroke. So they looked at men, 42% were men, about the age of 40, and they looked for the risk factors. And so they were followed up for 60 months, so long term. And what they found was patients that had that had a higher increased risk of stroke, either new onset or recurrent. They either had a history of a prior stroke, they had angiokeratomas, so consistent with more classical Fabry, renal dysfunction, left ventricular hypertrophy. So still with cardiac risk factors, global systolic dysfunction, they were all independent risk factors for increased risk of stroke. So heart disease, kidney disease, and presence of angiokeratomas, which in and of itself is not dangerous to your skin, but might be signaling fragility of the vessels. And so they define that. Further studies are needed to understand more specifically whether or not patients would benefit from antithrombotic therapy. So there are ways that we can treat and prevent strokes that you should have a discussion with your neurologist and cardiologist. So what about other cerebrovascular abnormalities in Fabry? Well, when we looked at the MRA, or the magnetic resonance arteriogram, so the MRAs are the vessels of the brain, they did see this dolichoectasia, which is tortuosity of larger vessels. So these vessels over here that are of a larger caliber were more tortuous and not as smooth. They also saw comparison with basilar artery diameters. They're not sure if that you can follow that over time as a real indicator of risk of stroke, but it seemed to correlate. So they're not sure. So they're looking for ways to use imaging to predict that too. Okay. So in a study in 2017, 13% of patients had this tortuous vessel, the dolichoectasia, and they were often seen with older age in men and those with high blood pressure or uncontrolled blood pressure. And it's more common in patients who had small strokes, old and new, strokes in the brainstem and in the white matter. There was also evidence of microbleeds. So sometimes it didn't cause a stroke, but it caused little areas of hemorrhage. So it looks like the dolichoectasia is associated with imaging markers of small vessel disease. So it's telling us that the blood vessels are not healthy, and it puts an increased risk of brainstem strokes in those with a history of TIAs and ischemic stroke. Okay. So how do we prevent strokes in Fabry? How do we manage cerebrovascular risks in our patients with Fabry? Well, as I tell most of my patients with rare diseases, we want to reduce your risk of the average person's, the risk of the average person. All of us are at risk of stroke if we have uncontrolled cholesterol, if we have diabetes, if we have high blood pressure, regardless of having a Fabry disease. So we need to get those under control, and you need to speak to your primary care doctor and your neurologist to see if your cholesterol levels need to be lowered. There are different guidelines for different patients. Then there's a discussion of whether or not you should be on aspirin. Now, some of you, that's already been decided because of your cardiac or your heart disease. So you're already on an aspirin or other antiplatelet therapy, or maybe even on heparin or Lovenox or Xarelto. And so that is going to protect your heart. It'll also protect your brain. But for those of you who are not yet on antiplatelet therapy, that is a question of if and when you should go on it. It is not without risk. So prior to having your first stroke, it should be a conversation with your doctor, because even baby aspirin can be dangerous. It can cause bleeding. So you have to look at all your risk factors. I can't give a blanket statement of advice that you all should be on one medicine or not. You need to speak to your doctor. Now, secondary prevention is what we talk about after you've already had your stroke. And there's different recommendations depending on whether or not you are already on antiplatelet therapy. So if you already were on aspirin, then you might escalate to something stronger. Now, aspirin is quite strong, and that might be you were not on aspirin and now you need to be on aspirin. And it also depends on your cardiac status. Do you already need it for anticoagulation because of AFib or placement of a pacemaker? Now, what about the other therapies in Fabry that are directed at Fabry disease itself? Well, we don't have very good data that says that enzyme replacement therapy is helpful at preventing stroke. There is controversy. Some people think, well, the enzyme does get into the blood vessel, maybe it helps the blood vessel, but we don't think it crosses the blood-brain barrier. There's conflicting evidence whether or not it's preventive of strokes. The oral therapy, now that would be interesting because that potentially could cross the blood-brain barrier. So Galafold. We don't know yet because the data, that's relatively new still. So we don't know if Fabry's disease-modifying therapy helps with the stroke risk, and it really relies on preventing other medical problems like high cholesterol, diabetes, and blood pressure, avoiding things like smoking, other types of drugs that could be harmful to you, those are the biggest ones there. Okay. So I'm just going to check for time, Jerry. It's 10 after 8. So the focus today was on cerebrovascular disease. Sometimes I do get questions because we're in the brain. What is this white matter? We talked a little bit about Fabry and white matter in the past and Fabry fog. So just to end with here, just like we have insulation of our electrical wires, we have insulation of the brain. And the insulation here is called myelin. And healthy myelin wraps around the extensions from the neuron called the axons. And that helps us to transmit our signals, our messages from one part of the brain to another part of the brain, to the spinal cord, and to the rest of the body. And so interestingly, we do see that this insulation gets damaged in Fabry disease. And so there's a whole category of diseases that harm the myelin. They're called leukodystrophies or leukoencephalopathies. And so Fabry disease is a vascular leukoencephalopathy or a white matter disease. But what we don't know is if we damage just this myelin, underneath it, the wire still works. So oftentimes you don't even know you have white matter damage until you get an MRI for another reason. I just want to highlight here that the white matter damage is not necessarily a stroke. You can have white matter damage occur without having a stroke. So it's not like there's a part of the brain that got cut off from oxygen. Why? Because that would kill the entire cell, both the myelin cell, the oligodendrocyte, and the neuron. Here, there's specific damage to the white matter, the insulation. And so we don't understand exactly why this happens in Fabry. And it doesn't necessarily correlate with a particular dysfunction. I can't say, unlike stroke, where I could say you lost your speech, I know it's on this side of the brain and this area, down to a really small area, or you've lost your ability to move your arm, I know it's on the opposite side in the motor strip. Here, you have a patch of white matter damage here or there. I can't tell if it makes any difference in your function. You could have completely normal neurologic exam and have damage to your white matter. So it's like a telephone wire. The message is still getting through. It's just the wires, the insulation's a little worn away. So we still don't understand the significance of that, but we do see it. So is it because there's some slow leak of the vessels or so slow damage from GB3? Possibly. Is it, what is this? But it can be completely asymptomatic as well, right? And it can be misdiagnosed as multiple sclerosis or other disorders, okay? How common are they? I'm not sure if this is reassuring or not. It could be in a way that since most of them are asymptomatic, but up to 46% of patients in this series, when we looked at 904 studies, 46 studies were looked at, and in those reports, 46% of patients had white matter lesions. That was 581 out of 1276, almost 50%. And the average age was 38 years. So 16% showed confluent, like a lot of white matter lesions. And both men and women were equally affected, but usually we saw more of this white matter lesions in younger men, just like with classical Fabry. Sometimes we see symptoms earlier in men. If you had classical Fabry, you had a higher likelihood of having white matter lesions as compared to the late onset cardiac variants or renal variants. And we did see increase in this in up to a quarter of patients over the 38-month follow-up. Okay, and this occurred both within men and women who were with or without enzyme replacement therapy, but we saw it earlier in age. Okay, we even see it in children and adolescents. We looked at MRI studies in 44 children, and up to 15%, 16% have asymptomatic lesions versus the control group. Okay. So again, but none showed microbleeds, all right? And 90% of the patients who had this also had symptoms of Fabry. So kind of connecting it back to stroke. Stroke seems to be related to white matter lesions, but not directly. It all might be just a marker that there's vessel fragility and vessel abnormalities causing both white matter lesions and stroke. It's not a one-to-one. Just because you have a white matter lesion doesn't automatically mean you'll have a stroke. That's important to know because white matter lesions are so prevalent, okay? It just might be a sense of the overall health of the blood vessels in your brain can be completely asymptomatic. We see it in patients with migraines, although to a lesser degree. People with migraines, many people out there, and whoops, we do an MRI and we see some incidental small white matter lesions. Again, that might be a measure of vessel health. But we do see as the burden increases, it might contribute in later ages to cognitive problems. We see that in patients with high blood pressure. We see it in vascular dementia, but it's not universal at all. Okay. And we don't think ERT, this is some of the studies, prevents these CNS, central nervous system manifestations, okay? So I'm gonna pause here because the rest are about cognitive impairment and depression, which I think someone else is gonna be talking to you about. Memory issues is if we have time, you wanna go over that, we can. So let's go forward. Okay, so let's just end on, you should have a neurologist involved in your care, even if you don't have active neurologic problems, at least have a conversation with the neurologist to understand your risk factors for stroke. I do recommend annual follow-up with a neurologist, more frequent if you have active issues. You should have periodic brain imaging, preferred MRI and MRA if it's not contraindicated to any cardiac devices, to assess for any hidden or strokes versus white matter lesions. Obviously, we should always do a comprehensive assessment looking at how your mood is, treating for depression, cognition, understanding if there's any memory complaints, understanding peripheral nerve involvement so we don't accidentally call something a stroke versus a peripheral nerve issue like the inner ear with vertigo and hearing and tinnitus, so cranial nerve 8. Obviously, pain can be managed by neurology. And then to look at stroke risk reduction, diet, exercise, weight control, review of your sleep, and then management of comorbid medical conditions to get under control, diabetes, cholesterol, high blood pressure, and then discussing the role of aspirin or other antiplatelet therapies. We really need long-term studies to better define the CNS manifestations, such as the age of onset, for white matter, rate of progression. Is there a connection to long-term stroke risk or dementia or any cognitive issues? So far, it's very shaky. Looking at future research possibilities, could chaperone therapy or other substrate reduction therapy help with the blood-brain barrier and this issue of stroke or white matter lesions? Will it cross it? Will it help? We don't know. We need long-term studies to do that. So in general, I think earlier diagnosis obviously is better with earlier intervention for neurologic disease. I didn't harp on this, but I really feel that, the neurologic complaints or the neurologic impact is seen in childhood as it manifests as the painful paresthesias of the hands, but also with the GI motility, which has a lot of, is a lot due to neuro, impact on nerves, actually. So if we can intervene early, we can help to prevent neurologic decline or dysfunction, especially with pain and GI symptoms. And maybe we'll see some stroke risk reduction if we follow certain small molecules further down the road. Just want to say thank you to everybody, and just a final goodbye to my research team at NYU. It's been a wonderful almost 10 years of working at NYU in the lysosomal storage disorders program. I'm hoping to have a replacement for me in the fall, but in the meantime, my team has been helping to make sure all our patients are well cared for as they find a new physician. But I will remain in the community and hope to be able to contribute in various patient lectures. Thank you.
Thank you, Dr. Lau. Thanks for your great support over the years to the Fabry community, and good luck on your next adventure. So I've typed a couple of questions in the chat box, and if anyone else has questions, would you type them in?
Yeah. Oh, I see some. Okay, excellent. Okay. Are complex migraines a warning sign of higher stroke risk? Now, that's a very good question. So even if in the non-Fabry patients, complex migraines are always treated a little bit more delicately, because a migraine in and of itself, classical migraine with aura, you have some visual disturbance, and then you get the classic headache. What we mean by complex migraines, for those who don't know, complex migraines are not just a headache. They're accompanied by a focal neurologic deficit. It could be slurred speech or numbness in the hand. It is a stroke mimic, but we assume stroke until otherwise proven negative, okay? So if you have your first complex migraine, I wouldn't say, oh, it's a complex migraine. I would go to the emergency room and get it checked out. Now, if you, after get checked out, and they really feel confident they can separate headache, migraine from stroke, and it's hard, because who's to say it's not a transient ischemic attack? Then, so then, sorry, I was reading another question as it came through. So it's really critical. I don't want to say one thing, or you don't know it's a complex migraine until you're thoroughly checked out. If you have Fabry, you err on the side that it's probably potentially a stroke. Get evaluated emergently. So if you wake up, I have a headache, and now I have numbness in my hand, that could be a hemorrhagic stroke. Headache, so blood can cause headache. Blood in the head is irritating. You go and get your CAT scan. Okay, thank God it's not a hemorrhagic stroke, but could it be an ischemic stroke? Yes. Then you need to go through a workup. It may not be right then and there, but you need to. So then you go through the whole workup and they say, well, we don't see any evidence. I'd still be very suspicious and go to a migraine specialist. I'm treating this differently in Fabry because we know you're at increased risk of stroke. So before you call it a complex migraine, they have to be very, very careful. So is it a warning sign of a higher stroke risk? Yes, because that might be misdiagnosed. If it's truly a migraine, it's just a migraine. But there is association with women, if they have complex migraines, you don't put them on oral contraceptives because you don't want to make them hypercoagulable. There is a connection. But before you call it complex migraine, assume that it's a stroke first and get evaluated. Okay, there's
Thank you.
so lyso-Gl3 seems to be a higher risk for stroke with higher levels of, well, we're trying to figure this out. I'd have to look at the literature because lyso-Gl3 is a good biomarker of storage, but do we really have enough data to connect it to stroke? I'm not certain. In theory, it makes sense because the more storage, then the more deposition in the inner wall, then therefore the stroke risk is higher. I'll take a look at it because I'm always skeptical because for a long time, people would say the ERT was helpful in clearing out the storage and therefore it reduced stroke risk, but the numbers were too small. It's hard because we can't even use it as a reliable biomarker in general about disease response to therapy. So we'd have to be very careful. Okay, seen by a neurologist in my area, was advised not to get brain imaging because it's too complex. Wow. I was told that the telltale sign of the difference between MS and Fabry is that white lesions will go into the brainstem with MS and not with Fabry. I'm not sure who said that. Okay, so we don't have a lot of data on MRI because they weren't doing the MRIs. And then those of you who've had to go through device implantation, you can't get an MRI. I don't understand what it means to be too complex. We give MRIs for a new headache. So this is how little you need to get a brain MRI. You have a change in your headache, not Fabry, not a rare disease. You're just the average person. You had a headache. It's now the worst headache. You can get a brain MRI. Most insurances cover it. So it's not too complex. Maybe it's too complex for interpretation. And then you need to go to someone who has expertise in Fabry disease or in leukodystrophies or white matter or leukoencephalopathies. They don't necessarily need to know Fabry, but they have to understand leukoencephalopathies. And so I think if you can, you should get a baseline MRI. Timing of that, I'd leave it to a discussion because I don't want every single person rushing in to get a brain MRI. I mean, talk to a neurologist. You should at least get a neurologist. I don't like when people come in and say, I need this imaging. You don't know what imaging you need because maybe you need actually some more focused imaging. But yes, I think in general, we should get in the habit of looking at the brain, not just the heart and the kidneys. We need to look at the brain and understand more because you see all these small studies. That's because we weren't doing them. It was hard to get MRIs, but now we can exome the entire genome. We should be able to get a baseline MRI. So MS is very complicated. You can tell it's not Fabry versus MS because MS comes and goes. So there's a lot of criteria to make the diagnosis of MS. It's not just about going to the brainstem because I have seen both. Okay. In general, MS will have lesions that are old and new. You can get active inflammation and demyelination, and it's enhancing on contrast. You don't need to know this. Your doctor needs to understand this. And so when a doctor mistakes your Fabry for MS, that means they don't understand Fabry. And so your local MS doctor should know. Most of my MS doctors, maybe they can't tell what leukodystrophy it is, but they can just say, listen, this is not acting like MS. If you have Fabry, I would highly doubt that you have MS, although there are case reports. So again, if you have white matter changes and your neurologist does not take into account your Fabry and calls you MS, please talk with someone who's knowledgeable because the MS therapies are not without side effects. Now, there potentially could be MS and Fabry together. I've heard the cases, but again, there's too often a misdiagnosis. You can differentiate MS from Fabry in many different ways. Okay, when you mentioned assessing someone for white matter lesions and risks, sleep. So the sleep, that's a larger discussion. When I get complaints about, and it's such a bad word, complaints, when people talk about cognitive issues, that's where I talk about they connect it to the white matter lesions. It's not necessarily connected. And so whenever someone has subjective cognitive issues, concerns, and I have a whole lecture on this, it turns out oftentimes the people who have or saying they have cognitive issues, they do fine on cognitive testing, but it's more about attention or executive function. And so you need to look for causes of that, reversible causes. Sleep deprivation can lead you to have memory issues, recall issues. If you have significant sleep apnea, it can really affect your ability to process speed. So before I diagnose it as related to your Fabry, I want to make sure sleep. So sleep is one of those things where I want to make sure is treated before I give you a diagnosis of dementia. Eliquis, I developed a clot in my jugular vein. I switched to warfarin. Can having Fabry make a patient hypercoagulable in and of itself? That's a good question. So hypercoagulability, why does a vessel clot? Well, how much do I want to go into this? It's not that Fabry causes you to have factor deficiencies or factors that cause you, like if you have a hematologic condition or you have cancer. but it does make you prone to clot because the vessel wall, it takes two things to happen to have a clot. The platelets and the muck have to stick, and the vessel is not smooth. So you have flow that's not laminar, and it's all turbulent because the vessel's tortuous. You're going to have more likely to clot. So in that sense, you are hypercoagulable, but not in the sense of having factors that are deficient. Do you see what I mean? So that's why you should have a discussion about when you should go on to antiplatelet therapy. I'd like to see more information about women of childbearing ages, and just in general about the use of other things that could be procoagulable. But generally, we're talking about vessels being prone to clotting. It's a hard question to answer like this. As an assessment tool for Fabry, how often do you recommend MRI? Well, again, I don't like to give blanket advice. So it depends on the patient. Definitely a baseline MRI is helpful. And then 1 or 2 years later, just to see if there's any progression. Now, it becomes academic or research if you're just doing it to measure white matter that's otherwise asymptomatic. And that could be very depressing for patients. And you have to really take into account, are you doing research or not? I'd like to know, you know, how it changes over time, but does it really impact you functionally? Obviously, whenever you have an acute neurologic change, you should get an MRI. So you have a sudden onset that you think it's a stroke, you're going to get an MRI. So every couple of years is a good, you know, base for that. I know you're going to a lot of doctors and you have a lot of things going on, but I would say definitely meet with a neurologist yearly and then go from there about timing of imaging. Is that easy? Is that a better, I can't do a blanket recommendation, but I'm very sensitive to the fact that I don't want you to do testing that's not warranted, right? If it's a research study, you might want to see it every single year for 10 years. But if you're not in a research study, I don't want to be doing research on you. Is it going to change my management? Even my white matter patients with leukodystrophies, I don't do it yearly once I get a sense of progression. If you're symptomatic, I might do it more frequently because I'm not sure what's going on. Okay. Any other questions or out there? Was this helpful? Was this a topic that you, so just feedback for me going forward, because I'd be happy to continue doing lectures, Jerry, and stuff. So, you know, I think stroke awareness is important regardless of Fabry status, and not a lot of people understand stroke. And the take-home points are that a sudden new onset deficit could be almost anything. If you're scared, go to the hospital. And really and truly, because until you figure out that it's just benign positional vertigo, which is not, because it's cranial nerve 8 dysfunction, but at least it's not a stroke, okay? Too often people sit at home and they like wait it out. Well, it's getting better, I don't need to go. That's the worst thing ever. I'm great that you got better, but that tells me your blood vessels are prone, or not hypocoagulable, are prone to stroke. And that means that you need to do something. Thank God it didn't lead to irreversible damage, but it's meaning that you're prone, you're one of the 25% that is going to have a stroke. So you need to have it looked at. So don't sit at home, please. That's the worst thing ever, is when I get a call from a patient, well, it happened, my vision went and it came back. It came back. Well, you know, and here's the other thing about timing. I can tell if you had an acute stroke within the first few days, but after a week, I can't tell. If it's small, I can't tell. So it's actually helpful to get an MRI within, you know, the first 3 days of having a stroke-like episode, because there are certain sequences as a doctor that I can look at. CAT scans are not going to tell you if you had a stroke or not, a ischemic stroke immediately. It's just to rule out bleeding. So that's another misconception. You go to the ER and they're like, oh, sir, ma'am, your CT scan's negative for stroke. Well, you can go home. This happened to one of my patients. That ER doctor was wrong. What did we do a CAT scan for? You can't see an ischemic stroke on a CAT scan unless it's really old. Okay, so all we're looking at on a CAT scan is that you're not bleeding, and then we decide if and when we're going to give TPA and if and when we're going to do an MRI. MRI has a specific sequence to look for an acute stroke. And it doesn't have to be done within that first 6 hours, but within the first 24 to 48 hours. If you can get a brain MRI done, I can actually look on a special sequence to see if you had an acute stroke. After 5 to 7 days, that signal goes away and I may not see any evidence of stroke. So I know I shouldn't have to educate you, your doctor should know better, but I have all too often seen ER doctors get falsely reassured by a negative CAT scan and your symptoms went away, wonderful. And then lo and behold, it was actually a stroke, or it was actually a stroke. So there was, maybe your deficits went away, but there is evidence on the MRI that there was a stroke. So that's technically not a TIA. TIA is resolution of symptoms and a negative MRI of the brain, okay? So anyone have symptoms and had a little bit of, and they went away, but they still have a stroke on their MRI, that's a stroke. Okay, is that helpful?
Yeah. Thank you, Dr. Lau. I think we're out of questions except for one more for me. And so thank you very much for the great presentation and for all the helpful questions and answers from everyone. And so the next thing, let me just address Jen's question about doctors. So, you know, there's not that many doctors with Fabry disease expertise around the country. And we keep trying to find them, but the best thing we have at the moment is just our Find a Specialist database on the website. And it really only addresses the treating physician. So we haven't even attempted to find neurologists and nephrologists and cardiologists with Fabry disease expertise. We know of a few around the country. So that's just a continual project on our part, is to list more doctors that have Fabry experience on our website. Other than that, we just find them from each other and hopefully they're close by. But it's just a continuing project. Go ahead, Dr. Lau.
Yeah, so this is hard because I'm leaving clinical practice at least full time. And what even before this though, my patients come to me from, I'm in the New York City area, so there's a lot of specialists. But if you're in a region where there's not a specialist, you have to unfortunately become the advocate for yourself and educate your doctors oftentimes, correct? You have to tell them about your disease, you have to educate them. What I recommend, I'm trying on my side by giving grand rounds lectures to other doctors, training the new people as they come into NYU, other people, and still collaborating and still trying to be present. But what you need to do is, what I suggest is, like, if you find a doctor you like, who's really enthusiastic about learning, they are lifelong learners. Doctors have to stay on top of things. You could inspire that doctor to become a Fabry expert. That's how I recruited my cardiologist at NYU. He was brand new. Oh, he's brand new. That means he doesn't know. No, he's brand new, and that means he wanted to learn. He went to all the conferences. He learned from the best. He had the best and brightest teach him. And so now he's comfortable. And now I had a cardiologist at NYU, Dr. Macera, who's well-versed in it. Same thing. I know this should not be on your burden. It should not be your burden to teach doctors, but maybe just inspire them to learn more. And then have them reach out to people like me. I have no problem talking to other doctors and educating them and having, forums like this. So for good or for bad, you might have to inspire your doctor. But I would suggest this. Regardless of Fabry, you need to go to a stroke center or be transferred to a stroke center. That's done within the 24 hours. I actually had to land a plane once, asked a plane land, because someone was having a stroke and I had to go to stroke center. It has to be a stroke center. It has to be, I would suggest from a neurology perspective, a stroke neurologist, okay? That's who you really need. And then you teach them and tell them, well, I have Fabry. They'll look it up and then they'll know, oh, small vessel problems. Okay, that's what you need. Okay, you can find a stroke neurologist. Dr. Longo. Oh yeah, Nicolo. Oh, sorry, that was a private message. Yeah, so there's a lot of geneticists out there that understand Fabry, but from a neurology standpoint, if you can't find someone like me who's neuro and Fabry, just find a stroke neurologist. Okay.
All right, thank you. So the next thing we're going to do, we'll keep working on our database and keep finding other doctors for you to tap into if they're anywhere near you. And so the next thing we're going to do is I have a few announcements as usual. And let me just pull those slides up. If I can break through all of my windows here and find the right one. Sorry for your patience. All right, we're getting close. Okay, I'm going to share my screen. Must be this one. Nope, it's not. 1 second. It's this one right here in front of me. Sorry, this part always baffles me a little bit. Okay. Can you see my presentation? Okay, great. Let me get it bigger. Finally. Can you see my presentation, everyone? Okay. So
what we see is slide 2, and it's just blank.
Yes, the slides. Yeah. Okay. So let me, I just have a couple. So what I usually do here is just tell you a little about each of our, the pharmaceutical companies that are working on Fabry disease, provide us an update of what they think the most important websites or notes that you ought to have to be able to get to easily. So we put them up here. Now you don't have to really memorize anything here or try to write it down. Just this is in the recording. So if you want to go back to it and look at this, you can go back to recording and find this slide. But it basically gives you either the important websites that the companies think are you should see at a minimum, or it gives you the clinical trial site if they have an ongoing clinical trial. So as you know, Sanofi Genzyme and Amicus, they have their primary websites. Chiesi has the same. They are still working on their approval process. And AvroBio, Sangamo, 40MT, Freeline, all have clinical trials ongoing for gene therapy. And then of course, Idorsia is not recruiting any longer, but they're still engaged in their substrate reduction therapy program. So you can find that slide in the recording. Let me go to the next slide.
Jerry, you're on a different presentation.
You can't see it?
No, you took a snapshot of one of my slides and there's.
Oh, geez, that happened when you were trying to get yours up. I could see one of yours, or I could see one of mine. Sorry, everyone. Oh, I'm having a particularly hard time with this today. New share. Now, can you see my presentation?
Yes.
Okay, good. So I won't go over all that, but I'll just, you can look at the slide and you can go back to it and look at it in the recording. The next thing I'm going to show you is how to get to additional information on our website. And most of you might have seen this already, but on the top menu bar on our website, you go over to company clinic information. If you select the pharma industry tab, you'll see a grid square for each of the industry partners. And if you select the read more button on their square, you'll find other resources that they provide to the Fabry community that you can access. Same thing with support organizations on the right. If you select the support organization tab, you'll find various blocks for the NFDF and for other support organizations like PSI and the TAF, the Assistance Fund, the PAN, and the different financial assistance programs, the family assistance programs, and various other resources you can find on the website also. We still have a lot of calendars to distribute. We're trying to get them out to everyone that attends these meetings at a minimum. And so if you haven't gotten one yet, you will. And then please share that with your family member and friends who may not have a calendar. Also, if you subscribe to the newsletter, that starts that process. If you're not already subscribed, I know you probably all are because you're in the meeting, but pass that information on. And the next meeting, like always, once this one's over, we'll disable the link and put up the next meeting registration link. And I think that is, oh, and this is, I left the slide in from last presentation, but Mass General is still doing their GI study and enrolling people. So if you are interested in that, there's some compensation for that one. Then please go back to that slide and contact Mass General. The next thing we're going to do, and I should have asked you to do this before we started with the presentation, I'm going to stop sharing, but our word for the drawing tonight is stroke. So if you go to the chat box and put the word stroke in, and then in a couple of minutes, screen sharing is stopped. Okay, I think we're back to normal. Then Brittany is going to do the prize drawing for us. So what's going on when in the background now, Brittany's looking at your answers and assigning you a number for everyone that responds to the prize drawing. She loads that into a random number generator, and in a minute she will give us the winner of the $100 Amazon gift card. So if you'll bear with us for just a minute, we'll be there. And then I don't think I have anything in my my storytelling part of this at the end while we're waiting, is I don't think I have any more updates on my heart transplant. I've still, I got my 13th heart biopsy, and it's still no rejection, and everything seems to be pretty stable medically and probably emotionally, but that's another story. I'm just kidding. So everything is good with my transplant. I'm feeling really good. And I'm going to tell you the same thing the next time I see you. So we're just waiting. Brittany, are you getting anywhere? Oh, are we still putting stroke in the chat box, or does everyone look like we've got most people?
I was just able to get a winner. Do you want me to send it to you or just let you know?
Well, you can just when you get a name out of the number random number generator, you can just say it out loud.
Okay, so from Mary's iPhone.
So Mary's iPhone. Mary, you're going to have to share with, well, you can get that from, you can email me, Mary, because I don't know which Mary you are. I might be able to find it in registrations, but we don't want to make a mistake. So either text or email me, and I'll know who you are to send you the gift card. I've got your email once I know for sure which Mary this is. All right. Well, thank you very much. We'll take care of that. And I think, yeah, okay, I got it. And so we'll see you next time. Thank you, Dr. Lau. Thank you, Brittany. Thank you, everyone, for joining us as usual. And we will see you again. Good night, everyone.